Hello, everyone. Welcome to today's MIT IoT seminar series. It is my great pleasure to introduce Professor Cecilia Mascolo from the University of Cambridge. If you've read Cecilia's bio, she is the mother of a teenage daughter, but also her part-time job or her second job is a full-time professor of mobile systems in the Department of Computer Science and Technology at Cambridge, where she also directs the Center for Mobile, Wearable Systems and Augmented Intelligence. And she is the deputy head of Department for Research. She is a fellow of the Jesus College, Cambridge, and she's also the recipient of ERC Advanced Research Grant. And before she was a faculty at Cambridge, she was also a faculty in computer science at University College London, and even before that, she received her PhD from the University of Bologna. She publishes high impact work, which has been shaping the field over the past few years. Her research is very exciting. She was, and it has received so many best paper awards. And she was also listed as one of the 10 women in networking and communications research that you should know. And you will get to know her and some of her work today. I'm very excited for her talk. She also serves on the steering, organizing, and program committees of mobile and sensor systems, data science, and machine learning conferences. Very excited for your talk today, Cecilia. Thank you so much for joining us and for making the time. This screen is yours.
Thank you, and I hope you can hear me well. And thank you for this invitation. I wish I was visiting Cambridge, the other Cambridge, which I like a lot. Instead, I'm here based in the other Cambridge, which you should also visit, which is very nice as well. So this talk is about two parts. One is perhaps more on the pandemic related, so how we use sounds to understand COVID diagnostics. And the second part is more about wearable devices and hearable, in fact, and sound, how we use that to detect behavior. In general, I won't give you the speech on what my research is about, but I will narrow it down to something specific to this talk. And in general, we've been working on trying to understand and gather behavior data that is difficult to sense, and trying to do that in an effective and efficient way. So what I mean by behavior that is difficult to sense is something that probably many of you are already also doing. So when you need continuous input, when in the past, perhaps the data that was coming of certain behavior was discrete, very discrete. And so now all of a sudden we can try to find ways to have continuous input data. Or when data or understanding of behavior requires user input and or user attention. So questionnaires, users clicking a button and doing things actively. And can we substitute that? Or sensing, where sensing is expensive or somehow inaccurate, and we haven't yet found a way to substitute that expensive way into something cheaper. Or when sensing is invasive or even dangerous, and we can try to substitute that. So this is very general, but I just wanted to give you the context of where this works fit in more general terms. And obviously, trying to do that and pushing the boundaries of what can be done from devices that are either just out there or perhaps they are the next generation. What can we do with a device that sits, for example, in your ear is one question that one wanted to ask. And also because often the elephant in the room in all of this sensing and behavior is privacy. Looking at solutions that use fundamentally, I'm a systems researcher to some extent, or at least at the fringe of that. So finding a technical solution to the problem of privacy is interesting. So using systems techniques that allow us to solve the problem of, can we still compute behavior, understand behavior, and perhaps do it in a way where the data of the user stays on the device as much as possible, or part of it stays on the device, is what is of interest. So all of this talk is based on analysis and gathering data of related to microphones and sounds for some sort of behavior understanding or diagnostic. The first part is diagnostic, the second is more related to behavior. And why would you do it from sound? Well, because many devices that are already out there or can be easily devised are can have microphones that are very cheap, and you can embed them in these devices. And so these techniques have the power of scaling to large populations and to countries perhaps that need to use technology that's cheap or affordable. And also a picture on the right, if you're looking for something continuous or with more finer granularity, the ability to sense closer to the user with something that continuously sits with you is appealing. A doctor can only perhaps auscultate your body whenever you are in a consultation with them, but perhaps a device can do much more. So that's the context. And as part of this, I have one specific large project that looks at techniques to build robust diagnostic models that consider the fact that devices are in the wild. So, this is not clean data that comes out of these devices. Tries to then embed these techniques in models that can run efficiently, possibly also on device. And the first thing that we noticed is when you try to build models for this, to understanding how sound can be used to understand behavior and understand perhaps medical history, then you need to have data. And the data that is out there is often limited to something collected in a very clinical setting, something very specific, limited, or also perhaps not collected in the wild. In particular, talking to doctors about how they train other doctors, you find out that often they train by listening to the same patient. So, the consultant listens to the chest or the heart of someone, and then the junior doctor then listens, and then they talk about what they understand. This is clearly something that for a computer scientist, the first question to the clinicians I talk to is, don't you have data banks? Can I get your data bank? Is that, how do you train your people? Don't you do that? And most of the time the answer is no. So one of the aspects of the project that I'm running is collect large data sets and try to go into hospitals, but also through devices to collect large data sets. So when we started this project, this large project in the end of 2019, we started to concentrate on cardiovascular. But I won't talk about cardiovascular because yes, we have a line of work related to cardiovascular, but immediately after COVID started to happen. And COVID is a respiratory disease, exhibits some respiratory symptoms, I should say. So colleagues of mine came to me and said, well, you have this large project, can you apply it to COVID? And so what we did in March last year was to push out an app that collected sounds of COVID, as we call it. This is in collaboration with two other researchers, obviously with a different background. You see their names on the screen. I could give a completely different talk on how difficult it was for us to push those apps at COVID times, an app that had a COVID in the name, through the Google and App stores. Conversations, you can ask me questions at the end, but I think I have a clear image in mind of how we could have a better relationship with Google and Apple on how to do research through their platforms. But we managed by pushing the right buttons and talking to the right people and convincing that we weren't quite just exploiting the event as we were accused of doing. So what does this app do? Well, this app simply asks the participant to breathe 5 times, to cough 3 times, and to read a random, and I realized how random this was after we deployed this, read the sentence on the screen. And again, I can talk about the randomness of that sentence later if I ask the question. So why would we collect this data? Well, the idea here is to use machine learning on a large scale data sets to provide a scalable, contactless, affordable test, which is an alternative to the current tests The analysis of the data to understand from your voice and sounds of your body if you or not have COVID is, in theory, very cheap. The threshold is very limited. But also, one thing that I would like to talk a bit further down is that this could just not be about diagnostic. It could be about progression. It could be about recovery. And it could be about other diseases as well. So this is just for fun. I know, there's nothing technical about this slide. This is the growth of our data set, which is crowdsourced. So the users contribute their data. The data is the sounds that I've indicated, but it's also the list of their symptoms, the list of their medical history, their location if they want to tell us, and their demographics. And if they've tested positive for COVID before. So we crowdsourced their tested results in the app as well, and we use that as a sort of ground truth to help that. This is probably the largest crowdsourced data collection of COVID sounds, voice, cough, and breathing, as far as I know, worldwide. And this is, again, another slide, because I do like graphs, about what we ask. And again, here we'll ask lots of questions about, are you COVID positive? Did you test recently? Are you not tested? Are you COVID negative? And in retrospect, this is quite confusing and we should have simplified. So, things you'll learn about your data much later. And just to make sure that we weren't collecting random data. I mean, we are collecting random data. This is crowdsourced. We even have people meowing into the app. So, it's a large data set, but yeah, with lots of variability. But these are the symptoms of the users who have symptoms, both positively, who said they're positive, they tested positive recently, and who said they tested negative. As you can see, as a sort of grounding this in it is the fact that the loss of smell and taste is something that users seem to indicate as one of the symptoms, and it corresponds to other studies that have used symptoms indicators to see if someone have COVID, and they relate this as a COVID symptom. The other thing that I would like to point out is that just the symptom of dry cough or wet cough is not something that easily distinguishes someone with COVID. So there needs to be something more than just looking at the symptoms to understand if someone has COVID just from data crowdsourced. And again, just because I think this is interesting, we have looked, I mean, there are various groups in the world, including some even in your own institution, that have looked at these problems of cough and voice for COVID. And there seems to be a sort of common ground in thinking that there are characteristics, both of the cough and the voice, that are specific to the disease. Now, these are clearly not simple to distinguish, and it could be easily confused with other diseases. And so there's a lot of research that needs to be done. But here you see there are a bunch of vocal fold movements after this is a spectrogram of 3 coughs of a healthy individual and a COVID tested positive COVID individual. And the spread over the frequency, the energy over the frequency is quite marked over the COVID cough, but also the vocal folds that you would have moving after the cough itself are less distinguishable. So, I'm trying to give you a little indication of what features one might want to try to look at in a spectrogram for this. This is a voice, again, the person reading that sentence that I mentioned on the before. The voice while reading in a healthy person would have all this harmonic informant very easily or reasonably easily understandable in the spectrogram, and some and less spread over high frequency as well. So these again are things that the community is starting to accept as possibilities for ways in which this can happen. And again, just because we're in the middle of this pandemic, I would like to make you hear, if I manage to find my mouse, a sample of a volunteer who had COVID and then got better. I have somehow augmented the data so that the person is kind of, the identity of the person from the voice is kind of more hidden. And so this is when she was sick.
Eu espero que os meus dados possam ajudar a controlar essa pandemia. Eu espero que os meus dados possam ajudar a controlar essa pandemia.
So, and this is when she was healthy again.
Eu espero que os meus dados possam ajudar a controlar essa pandemia. Eu espero que os meus dados possam.
So clearly very different sounds. I obviously picked one that was easily distinguishable from voice. This is Portuguese for those who managed to distinguish the language. Yeah, so of course, other diseases can create this sort of distortions, but there's a feeling there's something specific in this disease. And so just going into the more technical part of this, we have published a couple of papers that you find both on my website and on the COVID-19 Sounds website. The URL is up there. And we looked specifically at cough and breathing in the first paper, title up there, and specifically to voice in the second paper. Just because I always like, I get bored of talking of things that have been published a while back. This is just this year. In fact, the second one still needs to be presented at a conference, but I wanted to talk about our latest architecture and latest data analysis that we have done. So this is really where we are with the analysis right now. And this is yet not published, but I rather talk about the problems than the solution. The solutions you can go and look at. Our current architecture is such that we get spectrograms of our data, so spectrograms of cough, breathing, and voices, and feed them into an input layer, and then use pre-trained, we've tried various architectures, but here we decided to use a pre-trained convolutional neural network. This particular VGG is trained by Google onto YouTube audio. So it's a specific pre-trained network, which is then fed, it could be here, and this layer you could have a sort of max pooling layer, or in this case, we have a bidirectional gate recurrent unit that essentially kind of compacts the input of the VGCs so that we get as an output of that layer a set of features, so a feature vector for the three modalities. And with that layer of features, we then fit it into two dense layers, and we calculate a softmax probability, which acts as our prediction, and then use a binary classification task over that prediction to say, is this person COVID positive or COVID negative? What do we use it? Ground truth? Well, as I said, our crowdsourced data has as ground truth the what the users say their testing status is. Now, that could be a lie. That could be that they have not gone for testing yet. We have a few of those, and they might be positive when they've not yet been tested. And so we need to be careful in what we use as data for training, as a data for testing for this. That there are lots of problems related to this. People, lie. And also one last part where I think this all is very interesting, and at the level of real time, how this could be used is the longitudinal clinical progression. We ask users to tell us to use the app every 2 days. So some of the users, we'll see at the end, we have a graph on the distribution of how many people have given us more than one sample. And so we started to build a data set of people that started giving us data when they were healthy, and then they're sick, and then they are healthy again. And it's really good data to see how we can develop longitudinal approaches of predicting if someone is about, if their voice, personalized models for this. And I know you're all interested in results. This is one of our latest results, but I will talk about what we are doing more than what the results are. You can see some of the results in the 2 published papers. Our latest result on a data set that doesn't have any language bias. So the other issue is that for voice, but also and sometimes even for cough, we had unbalanced data sets. So for example, at one stage, we had, I think it was the English data set had mostly COVID positive people who actually had the disease, and the Italian data set, which was the other bigger one in our data collection, had mostly negatives. So what would a very smart model do? Learn that if someone was speaking Italian, they would be COVID negative, and if they were speaking English, they would be COVID positive. So we had to look at all sorts of these things to avoid, and we're still in the middle of it. This is a result over a just English speaking data set, which is reasonably small. The other things that we are looking at, and we've tried, I won't give you the results, but yeah, we'll put them in the next paper, is obviously this is for a balanced testing data set. So you have 50-50 COVID positive, COVID negative. Now, in reality, in a population, you won't have more than, hopefully more than 10% COVID positive. You need to make sure you spot them. You need to make sure you have high sensitivity, even when that number goes down. So that's really important. The other question most of you probably have in their mind is, well, what if it's a different disease? What if you have another type of cough? So we've tried 2 things. One didn't work. So we collected data sets that exist, which have been also collected with phones on coughs, labeled coughs from people who had other diseases. And we tried to mix them with our data. The result was, again, that the algorithms were smart enough to detect that there were different data sets, perhaps collected in different conditions. So we couldn't use that. Instead, we tried to test the model on groups of people that we have in our data sets that have declared they have certain medical history, such as asthma or other diseases, which are respiratory. And we could see that we were able to distinguish with reasonable accuracy. I'm not showing you the results because we have small numbers. Unfortunately, there has been no flu in the UK or anywhere else to allow us to compare with our data the situation with diseases that have some respiratory symptoms, but also other symptoms, and try to really have a control set that could do that. The other thing that we did try to do was to compare the results of our model with the results of some physicians. So can a physician detect COVID? So because of all the press release and coverage of this project, I had a number of doctors talking to me, and people that were really seeing patients of COVID all the time, and they were saying that they were able to detect it. They were able to auscultate and to listen to the voice, listen to the cough, and say, this is specific. I swear I can do it. So we used some of those, and so we gave them some blind samples that weren't labeled, and some were COVID positive and some were COVID negatives. And we tried to see if the model was better than them. The results were quite mixed. Interestingly, often the physicians agreed with each other. But the model was also able to spot some cases where the physicians had it wrong. And sometimes when the model had it wrong, the physicians were right. So we think the avenue here, which is interesting, is a complementary avenue, because it seems, at least, I don't think I have yet enough samples to say this with certainty. That's why you don't see numbers. I'm not there yet, but this is a speculative talk. And so I can tell you that I think there is a future where this sort of automated machine learning is complementary to the human ear, to the skilled human ear. Certainly, we also saw that perhaps some of the most junior doctors weren't as good as the model. And that's another interesting idea. And so the last part of this first part of the talk is about uncertainty. Whenever we talk about machine learning, we talk in terms of accuracy and how how good it is at spotting if something is positive or negative. But there is a sort of another phase to this problem, which we call uncertainty or interpretability. This is a paper, not ours, but is an example of how, so they used an image data set of diabetic retinopathy, and they were detecting using automatic machine learning, but they were also calculating the uncertainty over the prediction over the samples they tested. And when that uncertainty was too high, no matter how good the prediction was in terms of accuracy, they would then refer those for further inspections. And this not only meant that those cases were dealt with separately, but also that the performance for the remaining cases would improve. So we actually tried that. This is a paper submitted, as you can see from the date, just a few days ago, and I do like to push in the boundaries of what I present so that I get new ideas. But you can go, it's open, you can find an archive already. So I'm not talking about something we haven't yet made public. And the idea is the same. As you can see in the middle, there's the user architecture, but we solve two problems with this approach. One is that in general, I haven't told you yet, but as you can imagine, when you put out an app and you advertise it, especially on social media and things, you get probably mostly healthy, normal people picking it up. And in fact, we have lots of people that have either not been tested or have tested, in fact, negative, because especially now with increased testing, we have lots of people testing negatives, and that's a good thing. And the positive data set is a smaller proportion of that. So what we've done here is have an ensemble system where we have positive and negatives, and we use the positive set, sliding it over the negatives, and we have results from all this sort of models. And we use the softmax standard deviations of how these ensembles are working over the data to understand the uncertainty level of the prediction. So if you look at the graph at the bottom there, you see that generally the uncertainty over the data that had a label of false was higher in our data than the uncertainty of the label of true. This somehow is, in a way, a good thing. It looks like whenever the uncertainty is high, we could either ask the user to repeat the sound and to give us a higher fidelity sound, or perhaps ask for a test, ask for something else that is a higher entry, or do something else. So this is the idea of how we combine the technology with a more advanced high fidelity, how we can introduce high fidelity in the system, in this sort of modeling framework. Now, obviously, as I said before, we are, after all, systems researchers. So an idea that would be interesting is how do we go next about all this diagnostics? Can we then compute on device? Can we then allow all of this model to go down to your device and not send the data elsewhere? Can we do any of that? And can we do that also for uncertainty estimation? So down there, if for the more systems inclined, there's a paper that is already on archive that is related to not COVID, but how we bring uncertainty modeling on edge platforms. I think I will, for the moment, skip the progression of COVID because I don't have any results on this yet. You can ask me questions of that, and I will move on to the second part of the talk. I'm sure I'm leaving questions at the end just for timekeeping. So this work is again related to microphone, And it's about trying to see what we can do to understand behavior from hearable devices. So part of my team is working in this new hearable sensors and devices that are starting to be produced. I'm wearing some of them already. These are the normal, off-the-shelf ones, but we're trying to use platforms, either self-made or that can be customized to try a few things. And this work in particular is one that is, I should say, conditionally accepted at Mobis 2021. We haven't released this one because we are at the moment making the Shepherd's edits. So this work is about understanding how from a hearable device one could try to gather user activity and gesture data. In the two graphs, well, the two, let's say it's 4 lines, but coupled in 2 top and 2 bottom rows, you find the activity, which are each column, detection through an accelerometer, which could be in an hearable, or a outer microphone. So often hearables have microphones on the outside, but some, like some of the, I'll tell you in a minute, also have a microphone on the inside. So this is graphs of the various activity when the user is either not moving their head or moving their head. So first row is accelerometer when the user is not moving the head. Second row, accelerometer when the user is moving the head. Third row, accelerometer, external microphone when the user is not moving the head. External microphone when the user is moving the head. And here we see that there is quite a bit of distortion in the signal when the users are moving. Clearly, you can do some filtering and fix it, but this is not what this paper is about. This paper is about trying an alternative way of understanding activity through this sort of sound. Now, the idea is that with this sort of gesture, and I'll show you some examples in the video, just sort of gesture and activities resonate, generate vibrations in our body that can be then be heard inside our ear. And if the ear is then occluded, which is something that often this sort of hearables start to do, so you have this rubber thing that stops your ear there, this sort of sound waves get enhanced and you can hear these vibrations very well. Now, probably many of you have now seen, have now understood where I'm going with it, so I'll go straight to it. So this is the similar graphs that we had before, when the head movement is on the bottom line. The first line is when the user is not moving the head, but performing these activities. And you can see already that the signal is very similar, it's not much distorted by this effect. So the inner ear microphone seems to be giving quite a bit of signal of that. So what we did, because the existing commercial hearables didn't let us try things and gather the right data, we built our own prototype, of course, which is always very painful, especially for the less electrical engineering inclined. So what can we do? We looked at step counting, we looked at gesture recognition, and for the moment we looked at activity recognitions, but we think we can do quite a bit more. And so here is an example of, you see left, right earbud and in-ear microphone, so the external microphone, and the actions performed are by Don Guz, the postdoc doing this work. And yeah, you can see what he's doing there. Okay, let's stop this. Yeah. Okay, and this is, because I like videos, this is the tapping so that you know what kind of things we're looking at. sorry. So they're not synchronized, but you understand where the peaks are and what is happening. Oh, sorry, started again. I didn't want to do that. Okay, so I have 2 slides on performance, and then I can go back to allow you to ask questions. So here we're using data from a single user, left, right, and both ears with 2 different classifiers, like logistic regression and SVM. And we show that the activity recognition performance improves when you use both of the 2 earbuds. We also show the confusion matrix in figure B, which is quite good. It's able to recognize the various activities. And the table on the right is showing the difference in performance with accelerometer, external microphone, and the bottom is our approach with internal microphone, with or without moving the head, with or without music. I think the numbers mainly speak by themselves. The three columns are step counting, activity recognition, and gesture recognition. So this is, so here, I expect some of you have picked up that I said data from a single user. So we have tried over more than 30 users, 31 to be precise. So now here is a Leaveout model. So we build a model using data from 30 of them, trying it on the Leaveout subject. As you can see, for some in the first picture, for some of them, the performance are not very good. And so what we did is add some personalized data. So we use either 10 or 60 samples from the user. And you can see, especially for user 2, how the performance really increased to a reasonable samples, reasonable level, as soon as you start adding some of them, some of their performance. And in the graph, the last graph, you can see the 2 model for the precision and recall, how depending on how many personalized sample you add. And you can see that to get to a 90% accuracy is probably sufficient to get less than 10 samples. If you get to 20, you get very high. Now, the collection of this sample is actually not very complex for some of the activities, and we think it's a reasonable way to do it. The other way to do it is probably looking at collecting more data from a large variety of users, not just 30, and the model will likely possibly improve just based on that. One other thing that we discussed in the paper, I don't want to bore you with those details, is the effect of the ground when you are looking at activity recognition, and the effect of shoes of that. So in the paper, we have some analysis of those too. So I think for that, I will conclude here. I generally prefer to talk over questions. So the last thing I want to say is we're still collecting data for the first data collection. I hope you guys are all healthy, but healthy data and tested data is still very good. We're also distributing the data. The data is very sensitive because it contains voices. And so we are distributing the data through data sharing agreement. So there's a bit of legal to do if you want the data. We have distributed it quite widely. We haven't yet distributed the full data set, but the data set that we've used for the papers, we can give. There was also a data challenge on the voice data that has been run by InterSpeech on the voice data of our collection. This is a traditional Zoom picture of people who are actually doing all this work, which is obviously not me. And they know many more details than me about this work. And with this, I would like to take questions. Thank you very much.
Great. Thank you very much, Cecilia. Very exciting work and talk. Thank you for sharing it with us and for simplifying it for many of us to understand, and also articulating the complexity, both in the research as well as in the techniques. We have time for questions, so I'll open it up. I'll also allow folks to unmute themselves if they want and ask questions. But please, if you want to ask a question, use the raise hand feature or write the question in the chat. We already had one question, so I'll start with it. So the question was, does the variation in smartphone microphones affect the results? How does one handle these variations while collecting crowdsourced data?
That is a very good question. I would say more than, yes, so some microphones are low quality, but more than the microphone, the issue was with how the users decided to give the data. So some users, especially for the cough, thought that keeping the microphone very close would be the best way to do it. So they saturate the microphone and the data is not very good. We have a few of those, fortunately not too many. The voice is much better because and this, had I known I would have put more instructions there. Because I have to read this a sentence on the screen, they keep the phone at a certain distance, and that is helping a lot.
Wow.
Part of the collection is based on Apple phones that are a bit more standardized, so that's much better. But the Android data seems to be acceptable as well. But we're trying now to do a small-scale study on the effect of, if the user is lying down versus if the user is sitting, versus even if it has a mask. Yeah, there are lots of things to consider. It's an imperfect world.
Great, thank you. Isaac, you have a question?
Yeah, I had a question about the ground truth for the COVID research. It seems like, I mean, with COVID, there's different progressions of like where you're at with the disease. So I'm wondering how you kind of associate that with the data. Also, like if they got their test 5 days ago and are taking the speech recordings now, like how do you deal with those issues?
The only way we have to deal with those issues is, well, there are two things. One is that we ask them if they tested positive more than, I think, 2 weeks or 1 week. And so we have that sort of limited, very limited ground truth. But also we know the progression, even if we knew it was a day before, the progression of the disease is different for various people. What I think is actually more interesting, and going back to that picture that I skipped here. So we have some people that have given us data over time. And some of these people have somehow, if you look at the bottom picture here, I need to tell you what this means, but essentially blue means that this person has not been tested until here, red, when it has been tested. And then green, where it tested negative. So tested positive, tested negative. And here is, we think, I'm showing this because we think this is the person just clicked the wrong button in this point, but we didn't want to delete this sample. So, so here you can see that there is an area here before they go for testing where we don't have data, ground truth data essentially, but our model seems to, this is the result of our model, and with the variations, the confidence somehow. And here we think that the model is getting it right, that it thinks is already positive. This person was probably positive here, wasn't tested, and then it gets more positive. At this point here, even that goes up. And then at some point, the model declines and understands that the person is tested negative. So that's why I think this is very powerful. It really understands the person, if we could, this is a general model that we are applying at every sample, but if we could add some personal data samples to it, it would really become very, very, very strong. I think I took your question a bit further. So if you have follow-up, please let me know.
Oh, that was great. Thank you.
Venkat?
Oh, sorry.
Hi. So I guess this is a bit more open-ended question. So if you want to train on device while preserving privacy, how do we do that? I mean, people talk about federated learning and all, but how do you decide what model to train in the first place?
Right. So
in practice,
I don't think for this particular case you want to train on device. So I will answer your question in two parts. First part, I don't think you want to train on device for this particular one. What you want is probably a pre-trained model that has been developed for other users, that uses some of your samples over time while you give it to it to adapt the training. So you do some sort of further training on device. So you do need to do on device training, but it's not the whole thing. It's a bit less. And in general, it seems that I talked to a few people about training on device for this sort of devices that we talk about when we talk about mobile systems in general. And I think the agreement is the total training on devices perhaps not suitable for many applications, mainly because you would need a lot of data from that user to get somewhere. And it's much better to perhaps have a base and then try to do a little bit of transfer onto, adding some personalization onto that. And perhaps some further continual learning on device or, incremental learning on device based on that. But yes, so I know, and we are among a few people that are trying to see if we can do some of this on device. It's actually very hard. I don't think the community has done training on device yet.
Great. I have a question. If folks want to ask questions, again, please feel free to raise your hands or put in the chat. My question is, you talked about the model sometimes making being smart or making errors just because of how the balance is. Have you considered some of the conditional types of learning, like conditional GANs or any other types of models? I know you didn't go as much into details there as a way to try to address these problems.
So, I mean, we've tried to address the imbalance through ensemble learning, if that's what you meant. And we tried to look at the uncertainty of the softmax probabilities through the standard deviation, essentially, to model all of that. But we have not very much moved beyond that. It's a good idea. There are definitely other models that we could have tried to. Yeah.
By the way, is the data open source as well, or is it crowdsourced, in-sourced?
So the data is crowdsourced and not so we crowdsource the data and we distribute it based on data sharing agreements.
I see.
Because the voice has been deemed as sensitive, so you could take the voice data set and augment it with YouTube data and find out that perhaps some very famous people are giving us data and their medical history. So yeah, we don't want to do that.
There's also a question from Maria in the chat. Did you identify features in the COVID-19 project with large predictive power?
That's a very good question. I think the answer is no more than other groups. Because we don't identify features directly, we let the pre-trained model define a feature vector that we then use for the next layers. We didn't quite use specific features. In one of the works, if you're interested, there is the voice based work that I cited. Anyway, you can find those two in the page that is on the screen right now. There we use the more feature based learning, and the features that we use are typical features for speech. However, I should cite work of a colleague in CMU called Rita Singh, who has published on arXiv. I think there's still papers where she finds specific features in the voice, and they are related to the things that I've used at the beginning to justify the spectrogram of the voice and the vocal folds movements. So those are probably, I would think, after having looked quite deeply in all the literature that we've seen, that those are a very good examples of features that could be specifically embedded.
Cecilia, I have another question. In the project for comparing accelerometers of internal mics, it was, of course, I thought it was surprising that the internal mics did so much better. So that was very.
Do you find it surprising?
Yeah, I thought it was more than accelerometers. I would not have expected, but
Well,
I think.
I think it's because of this occlusion effect that really enhances those vibrations that you can hear. And actually having an accelerometer on your head is probably very confusing for the activities because your head moves, has other dimensions to move at. Another thing I should say is that there are some, I haven't talked about it, but there are some hearing aids and form factors issue by which perhaps you don't want to have an accelerometer as well, but you do need to have a microphone. So there are more than one reason, not just accuracy again. I never like answering everything by performance for having this. Yeah.
Just to be clear, surprising in a good way. Like
no, well, I understand, but I'm saying that there might be more than one answer. I should have given it as well. Yeah.
One question is, have you looked, or are you interested in looking into fusion of accelerometers and internal mics? Because I think that some of these, like the ear pods, probably have both in them.
Yeah, definitely. So I think we just, as a narrow contribution, we wanted to say, why not? Why not use this for this? And we probably even do one thing in defense of accelerometer is that perhaps we haven't pushed the boundaries enough of accelerometer. Maybe we should have applied more filters or tried to do more to make the accelerometer performance better. So let's not go down that route. The other route is, okay, well, with internal microphone we can already do this. Maybe if you have other sensors you can even do better, and I agree.
Maria had another question, which was, were you able to identify other types of user pathologies based on the voice and speech?
So the short answer is there's something we would like to look at. We don't have enough data for other pathologies. So we have some users who have asthma, and probably is the highest group. And we've tried to see if we can distinguish COVID with asthma, but not enough data yet. There are some other COPD is something that is declared in some of the results. The answer is, I think for the old project, we need much more data, and it would be good to team up. I know other groups have other data sets, trying to fuse them together and possibly trying to find a way to use them together, which we have failed to do with one of them, but yeah.
One last question. Redwan is asking, in the COVID work, did you try to include people suffering from regular cold in the negative class? And if yes, what was the prevalence? I know you said flu was a hard one because it was a low season.
No one, I mean, we had, you saw the list of symptoms that were asked by the app, and some, there was the symptom of runny nose, but actually it turns out runny nose might be a COVID symptom as well. So we don't have the ground to say someone is a cold versus COVID, right? That's another problem.
Is there a way for people to select that? Like, I actually had a cold a few weeks ago. I could have just maybe use it. Is there a way to select that?
No, there is a way to select. Your symptom is, I have a runny nose.
Okay.
As a symptom, and then we ask you, have you tested for COVID? And if you say, I have a runny nose, I've tested for COVID negative today, then we have that.
I see.
But that's the level, that's the extent at which we have that.
Okay, wonderful.
Thank you.
Great, thank you so much, Cecilia. Thank you everyone for the questions, for the fantastic talk, super exciting work.